Welcome to a new episode of Dysphagia Matters. It has been about time that we talk about dysphagia in patients with head and neck cancer. And this time our guest was none other than Professor Kate Hutcheson from the University of Texas, MD Anderson Cancer Center. Kate answered all of our questions around head and neck cancer-related dysphagia, how it presents, prehabilitation, and the instrumental assessment through the dynamic imaging grade of swallowing toxicity, or short DIGEST, which she and her colleagues developed. We hope you find it as interesting as we did. Enjoy! Hello, Kate, and welcome. Thanks so much for joining us today.
Oh, great. Good morning. Thanks for having me.
To begin with this episode, how can swallowing be impacted through head and neck cancer?
There's a lot of ways that swallowing can be impacted through head and neck cancer. If you boil it down to something simple, it's either the tumor or its treatment that are the primary sources of dysphagia in head and neck cancer. And it can be both a short-term sort of transient impact to swallowing with certain therapies, or it can be a chronic or even a delayed onset of dysphagia with other sources of impairment that can be lifelong and can progress over time. So there's a tremendous number of ways that a patient who has head and neck cancer or has had head and neck cancer in the past could develop a dysphagia.
What are examples for the delayed onset of dysphagia? How does that happen?
Almost always a delayed onset of dysphagia would be related to late toxicities of radiation therapy. So specifically, we know that radiation, sometimes people will say radiation is the gift that keeps on giving, right? So in treating the tumor, radiation, of course, injures the normal tissue in its path, in the beam path. And, classically, one of the drivers of chronic dysphagia has always been considered to be fibrosis, which is a scarring effect in the soft tissues and specifically in the connective tissues surrounding the muscles. And that absolutely contributes to the delayed onset of dysphagia, a sort of stiffening of the swallowing mechanism. The other thing that really contributes to delayed onset of dysphagia, what we refer to as late radiation-associated dysphagia or late RAD, is neuropathy or denervation. So specifically, we expect that about 10% of patients who have been treated with, current standard doses of radiation will develop cranial neuropathies as a delayed side effect of their treatment. And that's often the hypoglossal nerve, so cranial nerve 12, but also can be the vagus nerve, cranial nerve 10. And those late onset of cranial neuropathies absolutely then contribute to deterioration in the swallowing system, also in speech, so most patients who are coming in with late radiation-associated dysphagia or late RAD will have concurrent change in both their swallowing and their speech.
Okay, and you said that the tumor itself is also a cause for dysphagia, which I think makes sense. But what exactly is happening there? Is it just because the bolus has to take kind of another way around it?
Yeah, that's a great question. So tumor-associated dysphagia that you would see in a patient who's been newly diagnosed, the severity of it, as well as sort of the nature of that dysphagia is really going to be impacted, obviously, by both the size and the location of the tumor. And so the way that I often will teach this is that, think about the structure that tumor is arising in. So if it's in the oral tongue or the larynx, and then think about that structure's contribution to the normal swallow. And then you should arrive at your expectation of what type of impairment that patient may be experiencing. And then the degree of impairment can be predicted by the tumor's size, which is classified by the T stage. So tumors are classified as T1 if they're small and localized to one site. T2 is still localized to one site, but a little bit bigger. T3 is a little bit bigger, again, still localized to one site. And T4 is involving multiple structures. So it might be in the tongue, but also extending into, for instance, the floor of mouth or into the jawbone or something like that. And so you can really think about the degree of impairment based on the T stage, usually, and the nature of the impairment from the tumor based on the location, if that makes sense.
Yes, absolutely. Thank you. And so you've already mentioned the delayed onset of dysphagia. Is there a time frame, or how would you define it to be delayed?
Oh, that's a good question. So, practically speaking, we define a late onset of dysphagia or late RAD to be a clinical scenario where a patient initially after radiotherapy has recovered a functional degree of swallowing and then presents back, usually years later with substantial deterioration in their function. So I think it's not when it occurs, meaning like it isn't, that it always has to be 5 years or more, but it's more the fact that there has been a period of good functioning that precedes the deterioration.
And before this period of good functioning, it might have been impaired.
Yeah, yes, you're absolutely right. So most patients who are going through radiation will temporarily develop challenges with eating. They may not have an actually impaired physical ability to swallow, meaning that if you took them to video fluoroscopy or you passed a scope and tested them with fees, you might find that they are able to safely and efficiently move a bolus, but almost everyone during radiotherapy at, current standard doses along the pharyngeal axis, almost everybody will stop eating some degree of solid food. So they'll have an interruption in their eating for sure. There are some patients that will also have transiently impaired swallow safety or impaired swallowing efficiency, also from the acute toxicities of radiotherapy, that can improve. And it's those patients that improve and sort of recover to a degree of a functional swallow that then come back with deterioration that we consider to be patients that have developed late RAD.
Mm-hmm. And so when are people with head and neck cancer usually experiencing the first signs of dysphagia? Only when you start treatment, or is it mainly depending then on the location of the tumor and maybe even long before actually they get the diagnosis?
Yeah, I think that question is highly variable for across different patients. So in patients with advanced stages of disease, so larger tumors, it's very common that they would first develop or experience dysphagia symptoms at the time of their diagnosis. They might be experiencing them. So, prior to treatment. Other patients who enter their head and neck cancer treatment with an acceptable or functional degree of swallowing function, those patients might, if they were treated with surgery that impacts the swallow, they will typically have dysphagia immediately after surgery. Like that's an abrupt onset of change in the swallow. And then the great thing about surgery is that if you don't require additional radiotherapy, you should be recovering function bit by bit, day by day. Like the slope should be moving upward, as if you're thinking of the slope of recovery. Whereas with radiation, the slope can be a little bit more variable, and there are actually publications that show different sort of longitudinal trajectories of recovery of swallowing for patients going through radiotherapy. So patients that develop changes in their swallowing function in radiation, they typically would first become symptomatic about the midpoint of radiation. So radiation therapy is delivered, if you're dosing in, sort of current standards, it's delivered 5 days a week for roughly 6 to 7 weeks. And it's a cumulative treatment, right? You get a little bit of dose every day, building the total dose to the therapeutic target, right? And so most people, if you are thinking about radiation, most people will not experience a lot of side effects the first 2 to 3 weeks of radiation because that cumulative dose hasn't yet reached a high point. It's by week 4, 5, 6, 7 that if somebody's going to experience significant difficulty with swallowing in the acute setting, you're typically going to see it by then.
Okay. And then the indication for dysphagia treatment probably really depends on the course of the tumor treatment and everything else.
Absolutely. Absolutely. This is a disease site, not unlike some of the neurodegenerative conditions where you are projecting future functional loss. It is a disease where there is a significant emphasis on proactive models of care and sort of dysphagia prehabilitation. And the two opportunities for that most significantly are proactive swallowing therapy for patients receiving head and neck radiation. There's a huge body of literature that has sort of promoted and studied dysphagia prehab in patients receiving head and neck radiation for decades. And we actually just finished enrolling a very large international trial. My colleague Rosemary Martino and I co-led that trial. It's called the Proactive Trial, where we're looking at identifying the optimal timing, the optimal intensity of swallowing therapies delivered during radiation. But absolutely, proactive models of care there's a lot of evidence for them, and we're hoping that the trial will help to give the highest level of evidence for how to do it in the least burdensome way for patients and providers. But yeah, prehab has a huge potential in head and neck cancer. Radiation's where it sort of started, prehab for dysphagia in patients getting radiation. But there's also, I think the next phase is going to be prehab models for surgical cases. There's a lot that's sort of emerging in prehabilitation just broadly that's more like whole system, whole body. But I think that swallow specific prehab for surgery may also start to emerge a bit more because it's an obvious opportunity. For instance, if a patient's getting a partial laryngectomy, why not coach them on learning and habituating a supraglottic swallow before surgery? It's just an obvious opportunity that should promote a faster recovery of swallow safety and a faster sort of calibration to that new anatomy, right? So
yeah, absolutely. And what does a prehab treatment look like for people who get head and neck radiation?
The goal is to maintain and sort of optimize pharyngeal activity during radiation. You know that a patient's going to have toxicities that make eating unpleasant, and you know that most people will stop eating solid foods, and that, a large portion of patients, at least a third to half, will require a feeding tube to get through their treatment. And so the natural sort of load, if you will, on the swallowing system is diminished by radiation. And so prehab is really designed to help promote the philosophy of use it or lose it, keep that swallowing system moving to preserve its function. The two sort of activities or goals that can be given, one would be to exercise the swallowing muscles. Those are usually sort of pharyngeal swallowing related exercises, but also related to jaw range of motion for trismus. So things like the effortful swallow, the Mendelssohn are very commonly included in prehab exercise sets. Misako is commonly included. Jaw range of motion is commonly included. Supraglottic is also commonly included in those sets. And then, of course, just keeping a patient eating, which seems like low-hanging fruit, but the goal would be to make sure that we're promoting ongoing swallowing, but also maintaining swallow safety and efficiency, and also promoting swallowing things that are a bit challenging for the system as much as able, so pain management so that you can keep swallowing soft foods as opposed to going all the way down to liquids if that's possible.
Yeah. Okay, great. And can you tell us already something about the frequency and the dosage of the treatment? Do you already have results from the proactive trial?
So we don't have results from the proactive trial, and dosing wasn't really a question in the study design as far as exercise goes. The exercise dosing in that trial was based on a systematic review of the literature and based on the most common dosing that had efficacy data. And so in the trial, the dosing is 10 repetitions, a set of 5 swallowing exercises, 3 sets daily. And at the time that we designed the trial, that was the dosing that had the most evidence. And the way that the trial sort of compares high intensity versus low intensity dysphagia prehab is considering the option of eating-based therapy with or without exercise. So high intensity is prescribing swallowing exercises as well as eating-based therapy. It's a program called Eat All Through Radiotherapy, Eat RT, which has just some structure surrounding the concept of keep eating. So patients are randomized to eat and exercise versus eat only, versus a reactive model where they get symptom and chart checks once a week and only begin therapy once they're highly symptomatic.
So moving on to diagnostics, together with your colleagues, you developed the dynamic imaging grade of swallowing toxicity, or in short, DIGEST. Why did you feel there was a need for this, and how did you come up with the name?
The name's always the fun part. I'll start there. So the acronym for DIGEST was initially VSGHN, and it was Video Fluoroscopic Swallowing Grade for Head and Neck Cancer. And my colleague, Dave Fuller, who's a good friend and a regular collaborator, and I were talking about the project. That's what I had labeled it in the initial grant application. He said, "Oh, Kate, that won't do this." a very boring name. And so we just sat there brainstorming eating related acronyms and came up with Digest. And he's right, it's far better than VSGHN. But if you go back into the archives, that was the original name in the original grant application. But yeah, how we came to develop Digest, I actually was pretty resistant to, I didn't want to like put another swallowing measure out into the world because there are so many of them already. And my former chair, Randy Weber, who has been an amazing mentor and advocate for me over the years, kept pushing, saying, I really do think that there's a need for a measure from video fluoroscopy that is able to be interpreted easily by people that aren't swallowing specialists. His argument was essentially that a lot of the measures that we used and we would include in research studies that incorporated video fluoroscopy as an outcome measure in head and neck, that those measures didn't have a lot of meaning to a non-swallowing specialist. And he, made me sort of pause and reflect that if we could somehow take existing measures and make them interpretable to non-specialists, that could have a lot of impact. And so the idea with Digest that I sort of formed after that bug was put in my ear was, could we take standard ways that we look at swallowing already? A lot of clinicians already do the penetration aspiration scale or use it in their interpretation of the results. A lot of clinicians are already interpreting residue severity somehow. Could we look at those factors that we already are rating as part of our review of the study and systematically map them to the way that we grade toxicity and cancer? Because I was approaching this obviously as a cancer provider. And the way that toxicities are graded in cancer is universally in the US at least is through the CTCAE, which is very similar to the EORTC methodology that would be used in Europe, right? There is a taxonomy for saying this is a mild toxicity of your cancer. This is a moderate toxicity. This is severe. This is, a life-threatening toxicity. And that's sort of the goal that we had with Digest, was to map the results of video fluoroscopy to this universal framework for grading the severity of a toxicity from cancer.
Yeah, really interesting, especially with the name.
Yeah.
You usually don't get those inside information. So can you maybe tell us what the Digest then actually is? You've already said a little bit about it.
Yeah. So then what it is actually a decision tree, right? At the end of the day, it's a decision tree that looks to reproducibly use the pattern of penetration and aspiration events and the pattern of residue over the entire swallow study, whether it's video fluoroscopy or FEES, to derive a reproducible grade of the severity of the study. So like my mild is your mild because we're using the same exact logic to say this is mild, or we're using the same exact logic to say, no, this is severe. You get an overall grade, which is 1 is mild, 2 is moderate, 3 is severe, 4 is life-threatening or profound. And that's because those are the grades of the CTCAE, the toxicity grading framework for cancer. You get the overall grade, but then what I find actually probably the most useful in my clinical practice as a speech pathologist is the profile. So you also get a grade for safety impairment, and you also get a grade for efficiency. So your overall Digest, let's say, could be a grade 3 result, but that might be S1, E3. And what that means is it's mild safety impairment, but severe inefficiency. And for those who are practicing in the clinic, you can kind of picture that swallow a little bit by that profile, the same way that if you practice in cancer, you can sort of understand that a T3N0 cancer is very different than a T2N2, if that makes sense. And so it just kind of gets you in the right lane to think about the nature of the functional impairment.
Yeah, that's interesting. So ideally, all parts should be probably documented or reported on, shouldn't they? Because just the overall grade, it's interesting or relevant, especially maybe to the people living with the condition or caregivers, kind of knowing where they're at. But then for us as clinicians, it's really important not only to look at the overall score, but also having a bit more differentiation between the safety and the efficiency, as it makes a difference, of course, if the safety or the efficiency is more impaired.
Yeah, absolutely. I haven't ever really thought about making that overt. in my practice and in our practice here, we of course report the full grade and the profile. But absolutely, if you're just reporting the overall grade, you're really losing important detail, and you had to have that detail to get to the overall grade. So report it all.
Yeah. You have it anyway.
You have it anyway. It's not any extra work.
But do you know how it's like dealt with, or what other clinicians are usually doing if they report just the overall grade or if they report on all three grades? Do you
That's
know
a great question. No, I don't know in practice outside of our walls here at MD Anderson what is done. Here at Anderson, we just had the opportunity to complete what's called an implementation evaluation. So just looking at how feasible it was to use the tool widely in our practice after we developed it. And we did find really high use. So I think our data set was about 13 or 14,000 swallow studies that had been done in the 6 years in our clinical service after we implemented Digest. And we found that over 90% of the time, the Digest grade was reported in the electronic health record, and most of the time with the safety and the efficiency profile. So here we do that. And then we also pair that with the MBS IMP, because Digest is giving us sort of the, functional endpoint of the dysphagia, if you will, like how is the bolus being cleared? But obviously it doesn't tell us anything about the physiology of the swallow. So we pair that with MBS IMP for the characterization of the physiology.
Yeah, that makes sense.
Yeah.
Do you have any idea about how people report it in the literature in research studies?
Yeah, I think that the way people report it in research studies is a little bit different than it might be used in clinic, right? So I think in the clinical setting, absolutely all three, the safety, the efficiency, and the overall get reported. The research reporting really depends on the research question, right? There are research questions where the overall grade is probably sufficient, and there are research questions where it makes sense to understand the safety and the efficiency profiles of the patient in addition to the overall grade.
Okay. So when would you recommend to use the Digest, and when is it maybe not indicated to be used?
Yeah, great question. I would say that just at a high level, just thinking really practically, that Digest makes sense for use if the type of dysphagia that you are evaluating manifests in penetration and aspiration and or pharyngeal residue. If so, Digest probably has some relevance, right? That's not to say it has like psychometric data demonstrating its validity in that clinical population, but you could think that that might be an appropriate group to, for instance, study whether Digest works, right? The populations where it doesn't make sense that it would ever really be valid are populations that are experiencing dysphagia, where despite having swallowing impairment, once they trigger a swallow, there is no penetration and aspiration or pharyngeal residue, then it's not going to measure impairment in that patient population. And a group that I could think of would be like a group that has a lot of oral impairment, but a very functional pharynx. So a type of patient who maybe has a lot of perseveration in the oral phase or oral preparatory phase of swallowing, or even just a significant delay in the pharynx. But once triggered, there's no penetration, aspiration, or residue. It's not going to pick up on that nature of efficiency.
Yeah.
So if it's timing or if it's oral, it doesn't catch it, if that makes sense.
Yeah, it does. Thank you.
And do you need any sort of training to be able to use Digest?
Great question. I mean, the short answer is we don't know for sure how much training you need. We do have training that was redesigned and relaunched this year, just about a month ago, to be a completely asynchronous virtual training. We initially piloted a training that was live and then repurposed it to be an asynchronous training that's more self-paced and able to be done on your own schedule. We've done some studies of reliability, and what we have identified at a high level, and this is of course in, like fairly advanced swallowing raters, like folks from labs that are studying dysphagia, is that about 75% of raters without any training are pretty reliable using Digest, and about 25% are not. And that regardless of your baseline reliability, you tend to have improved reliability after training and improved confidence. We developed Digest and specifically put it in the public domain because we wanted there to be the opportunity for natural dissemination. And then we're right now studying to see how much training is needed for it to be used well in the clinical setting.
Great. So probably I could think that training might be helpful and ideal, but maybe not necessarily really needed.
Yeah, I think it's probably going to make anyone more confident, and it will probably make you more reliable in difficult cases, right? Because those are the ones where your reliability sort of falls apart. But the logic is pretty straightforward. And I would say that a lot of people probably can do the basics just by reviewing the flow sheet. What the training does is sort of help you understand how to make sure you're using it the way we intended when things aren't as straightforward, if that makes sense.
Yeah.
Which video
And
fluoroscopy and fees are not always straightforward.
yeah, that's true. Okay, so initially you developed the digest in 2016. In 2022, you published a refinement, so version 2 of the digest. What has changed, and maybe can you explain why you've changed some things?
Yeah, very simple. We refined the branching of the decision tree for mild safety grading. And this was based on observations that there were a couple of scenarios where the original S1, which is mild safety, on the original flow sheet, both under and overgraded certain scenarios. And so what you'll see is an adjustment in that branch. You know, when we did the psychometric review of that change, it only changed a very small fraction of swallow studies, but we felt it was important to correct those if we saw it systematically not grading them appropriately.
Yeah, great. Thank you.
Initially, you developed and validated the digest for video fluoroscopy and in the head and neck cancer population. So besides the population of head and neck cancer, for which other populations has it been validated?
So ALS and stroke in video fluoroscopy have been validated. There are validations that have been conducted and presented at the Dysphagia Research Society. Both of those publications should be out this year, I believe. So there is a growing body of evidence to support the validity of digest in patients with neurogenic forms of dysphagia, which is great. There are a couple of new validations that I would say are in the pipeline, and one of those is in dementia and aging populations with cognitive impairment, and the other is in ACDF, so cervical disc fusion populations. And then there are some expansions that we're looking at in head and neck, specifically with a grant that we have funded here in our lab. And one is looking at the operationalization of the efficiency grade to grade swallowing after total laryngectomy. And then the other is figuring out how to best account for oral impairment in patients who also have that, and specifically in patients with oral cavity cancers.
And that was all during the use of video fluoroscopy?
Yeah, that's right.
And has it also been validated for fees?
It has. So Heather Starmer led the adaptation for fees. We had an Ash Foundation grant to do that, and that was published a few years ago. And that validation sample mimicked the head and neck cancer sample of the video fluoroscopy, like the original validation from video fluoroscopy. Since that time, there has been a publication for digest fees in Parkinson's disease, so some emerging evidence for neurogenic dysphagia and fees. And then in pipeline for fees, there's also a stroke study by Lisa Everton out of the UK.
So it's quite a broad instrument then, or broadly for many different patient populations.
We hope so. I mean, that's what we're starting to see, is that the performance is pretty stable across different populations. One of the things that we're really hoping to, that I think will be important as you look at different populations, is the bolus protocol. And so one of the questions that we are trying to tackle right now in our R1 that we have funded in our lab is trying to identify what are all of the sort of differences in bolus protocol that you're able to implement and still get a valid digest grade. And we're also looking to understand whether there's like a minimum bolus protocol that should be followed to give you a digest grade. And the reason that that's important is it's a pattern-based assessment. So there does need to be some repetition of certain bolus types in order to see pattern. And that might be harder to achieve in some clinical populations than, for instance, a head and neck cancer population. So it's really, I do think that as we think about the scale having broad applicability, we do have to tackle that question and make sure that we can understand how it scales to different clinical populations who need a different testing protocol. The idea isn't that you have a single digest bolus protocol, but that you can use it across various bolus protocols.
And with bolus protocol, do you mean how many boluses of different consistencies a patient?
That's exactly what I mean. Yep, exactly.
I've got another question going into that direction maybe, because in the digest flow diagram, it says that the maximum PS score, for example, is then also defining the safety score. How does that work then if you have, for example, 8 swallows and one is very off, but the other ones are kind of okay?
I'm so glad you asked that. That's exactly what it's designed to account for, right? So let's just give a scenario there. So let's say you had 8 swallows, let's say 5 or 6 of them were thin liquids, right? And maybe a couple were other things. And on one of those thin liquid trials, you had a PAS score of 8, but all the rest were okay. Maybe 2s or 3s or 1s. That would be a digest safety score of 1. So it's essentially the logic looks for the highest degree of penetration of aspiration and then looks for the frequency with which that happened, as well as the amount with which that happened. So if you had a single episode of trace silent aspiration, so a PAS score of 8 over multiple boluses in the trial, that would be a safety grade 1. If, however, let's say you had 3 penetration aspiration scale scores of 8 over 5 or 6 thin liquid trials, that would be a safety grade of 3 because you're chronically seeing high grade airway entry.
Okay, so it does take into account that maybe there's just one swallow that is not going perfectly, but the other ones are still fine.
Exactly. Yeah, exactly. And just to give another example, if there was a single penetration aspiration scale score of 3, for instance, but everything else looked fine, then the patient still would be a safety grade of 0.
Okay, great. Thank you.
Yeah, thank you so much, Kate. Is there anything you would like to give as a take-home message to our listeners?
We've talked about 2 of my favorite things. So we've talked about dysphagia management and characterizing dysphagia in patients who've had head and neck cancer and how we can, promote their most full recovery. That's one of my favorite things. But we've also talked a lot about digest. And I would say that the takeaway that's important is that no tool is going to be like universally driving your clinical practice. And so we've talked a lot about digest, but there's a lot of evaluation tools and measures that we use in our characterization of head and neck associated dysphagia, and both in research, but also in our clinical practice to help us make decisions. And so by no means do I want this podcast to give the impression that, digest is really all we're using or clinically implementing in the space. It's a tool in our toolbox, and we find it to be an incredibly valuable tool, but we also find a lot of other tools to be valuable and to complement it.
A big thanks to you, Kate, for taking the time and sharing your valuable knowledge with us today. Thanks so much for listening. We hope you enjoyed this episode. As always, if you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website at dysphagiamatters.org. Take care, everyone.